No, you're good.
Yeah. Would you like me to set up Zoom?
I think we're okay. I think Christopher came down and worked on everything.
Awesome.
I hope.
Your tie is lovely.
Thank you.
Hey. Hey, congrats on your match.
Oh, thank you. Thanks.
Yeah. I'm sorry.
Christopher, can you hear me? Are you upstairs?
Oh, my goodness, yes.
How are you? Great to see you.
Great to see you. This week is doing so busy.
Oh.
How are you doing?
Oh, good, you're good.
How are you? It's good to see you. I haven't seen you in like 33 years. I'm very close friends now with Mike Ulas. Oh, really? He's back in town. Glad to hear that. Yeah, he's a hospitalist in Butterfield. He's gonna be switching jobs in but I have
Oh.
swimmer
You wanted to, or is Zoom? Thank you.
Spawn and David Thompson, the second year.
Yep.
Okay, so everything's for.
Oh, my goodness.
After,
Brings back second year.
Oh, thank you.
Oh, like just saying how proud and how astounded I am.
Okay, so my slides are up. Your slides are up.
You're big, right?
We're set to go.
Thank you for coming.
Okay.
This means so much.
Okay.
It's really nice to be here and get to see this character. And actually, Paul made the dean of medical school. I could
I took your picture? Oh, I took a little.
I would
informal
love
one,
it.
Absolutely.
My hair okay? Come on.
Oh, yeah. Okay. Thanks so much for your help. I'll wait a few more minutes before we get going. Well, we'll see how many people are in the room. No later than 5 after, I don't think. Yeah, we have the room. Oh, okay. The other thing is our speaker's gonna be picked up about 1:30, I think. Oh, thanks so much.
You might mention that because I just put that in for you.
Okay, thank you. Appreciate it. Thank you, Chris.
Whenever you're ready to start, I'm just going to launch and
Okay.
I'll
Okay,
As far as the stream goes, we're not gonna do the whole start now or 3, 2, 1.
oh, okay, okay,
Whenever you're ready, just give
Okay.
me about 20 seconds.
okay, thank you so much.
I saw you around this.
He said, I
Came
can't
back from
remember
summer.
exactly what he said. I was misguided.
I did the AOA talk, and I've done SGA,
Why am I having this
How do I guilt
conversation?
Casey Gynecologics.
So it's
That's the
interesting
one up.
what some of our
And
instructors
that was several
think
years
and
ago.
believe.
Happy birthday.
Oh, thank you.
Is it your
Yeah.
birthday today?
Well, not getting to it.
Saturday, happy birthday. What are you doing for your
A
birthday?
fun weekend, my parents are coming to town.
Oh,
Good to see you guys.
that's
Just
great.
driving the kids home, it's just so fun. There's sporting events.
Of
I'll
course.
take you for the.
Yep.
Should we do a picture of the three of you?
Yes, that'd be great.
I can do the three cameras if you like.
Then I'll have someone. Will send them to us.
Okay.
You want me to do it?
Am I sure? Probably.
I tend to do groups.
Ready? Smile, and what a beautiful picture.
Thank you.
You'll send them to us, yes?
Yes, I will send them.
Thank you. The town hall's great.
You got this.
That's my whole. Yes, 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 okay. Do I? Oh, yes, yes, yes. See the nurse, okay.
Yes, less distance in the heels.
Amen to that.
Lisa was always a front row kind of girl.
Welcome to the AOA Annual Conference. Thank you for coming today. I have a few slides to show and then we'll introduce the speaker. So we've been doing some business. Some new members were elected just recently. Their names are on the slide. These are junior AOA, so they're elected in year 5. I won't read the names to you, I'll just show them to you. This is a list of students that were elected last fall, senior AOA. Lots of people here. Again, I'll give you a few seconds to look at things over. Okay. And then some other members that we elected just recently were some residents and fellows. Their names are here. We can elect 3 per year. Had a representation from several different departments this time. These are the student officers for the last year. Junior AOA a year ago. Okay. I also want to mention this. Carolyn Kukine Award from AOA. They are very generous in offering a student research fellowship. So it's $6,000 for a year, $2,500 up front, $2,500 at the end of about a year when the final research presentation is sent to AOA. And then in the meantime, $1,000 for travel and presentation expenses. So it lasts a year and a little bit more, and it's very generous. And one of our students won this award this year. We had several win it in the past, and so it takes a lot of work. Here's the title of the presentation. Nitin Nadella won the award. Is he here? Oh, there he is, right there. Okay, thank you for coming today. Worked very hard on it. His mentor was Dr. Wacker. Okay, so we'll look forward to seeing your final publication when you're all wrapping this all up. Okay, so those are all my slides. Now I want to introduce the speaker today. We're really fortunate to have Dana Thompson, MD, with us today. She received undergraduate and medical degrees in the 6-year MD, B.A. MD program at UMKC. She completed a master's degree in clinical outcomes research at the Mayo Clinic Graduate School of Medicine and an M.B.A. from National Louis University. She's fellowship trained in both laryngology and pediatric otolaryngology. Spent 18 years at the Mayo Clinic, founding chair of the Division of Pediatric Otolaryngology, achieved the rank of professor in 2011, expert in the surgical treatment of complex airway, voice, and swallowing disorders for infants, children, and adults. 2015 Gabriel Tucker awardee from the American Otolaryngology Association for outstanding contributions to pediatric laryngology. Published more than 70 publications and 20 book chapters. Currently vice chair for the Department of Surgery and the executive physician director for ambulatory practice at Lurie Children's Hospital in Chicago, where she is committed to the creation of care delivery models to optimize access for equitable and fiscally responsible care for children. Please join me in welcoming our AFA visiting professor this year. Thanks so much for coming.
Do I need to
Escape.
escape?
Sorry. Yeah, just escape and then your slides should be right there. Or delete them, it doesn't matter. There.
There we go.
There you go, okay.
Good afternoon. It's really just an honor to be back. This is a homecoming. This morning or afternoon, I'm going to speak to you about an area I am incredibly passionate about. It's advancing health equity, but it's also looking at it in the face of value and how we spend our healthcare dollars. I've been speaking on this topic for probably about 8 years now, and I've had to evolve it each time I deliver this. And in particular, I had to really think about today and reframing in the era of backlash around concepts around equity, diversity, and inclusion, which is really why I'm going to talk about value today. And as we think through care delivery in the 21st century. My disclosures, firstly, it's an honor to be here. I will present some proprietary technology that's in development. That's really my only financial disclosure. My perspective is that of really a lived experience in observing healthcare delivery in 3 academic medical centers. And in the delivery in the era of escalating cost, and huge health disparities. It's really in the frame of a context of a discussion that is evolving around DEI, and I will have some frank conversations today, and really nothing is intentional to be offensive, but it's really intended to generate self-reflection and thought of how do we move forward. So I just asked for that psychological safety. Goals today are to discuss health equity and cost containment and to really understand that neither are possible without focusing on value and understanding the value in the areas that we spend most of our money is social, behavioral, and environment factors that drive health outcomes, which is contributing to the escalating costs. And really, we have to focus creating value by looking in those areas. The escalating costs as an answer, the Institute of Medicine has really come to what we call the quintuplet aim for better health and an improved economy, and really thinking through all the facets of care delivery. And it's really a balance of access, cost, and quality, and really paying attention to what we call the triangle of iron medicine, or the iron triangle of medicine. How many in the audience really understand value-based medicine? Just a show of hands. Okay. This is a concept I think I probably actually thought of my entire career, but didn't know that there was a name to it. And I'll kind of describe how and why I got there. But it's really thinking through what are the drivers. And I really think that if we align our incentives in healthcare to value-based medicine, that we'll have incremental solutions to some of our health equity issues. But we have to understand that the United States is a market economy and driven by many economic factors that have also created some of our societal opportunities and challenges. And lastly, we'll evolve to discuss really the role of medical education and the healthcare team to be part of the solution. I'll give some examples of Test of Change, what we're doing in Chicago. My perspective is, I'm just going to give you a little history of my family and my background. It's really an honor to have my nephew and my brother here in the audience today. So I just want to recognize, thank you for coming. My dad was a obstetrics and gynecology physician. He knows Peter Greenspan. In fact, they worked together. He trained here on Hospital Hill. It was General Hospital number 1 and General Hospital number 2 were the precursors to our primary teaching hospital, Truman. So my father was in one of the first residency classes that was an integrated program. So this is in the mid-1960s. So in 1964, he showed up here from Meharry Medical College and was one of the first African-American physicians in the residency program. He was a community-facing physician. He practiced in Kansas City, Kansas. He believed in the concepts of health equity and access. He reduced the preterm labor rate in his community to 10%, which is unheard of in that time. How did he do it? He made sure that his patients had access to vitamins and ultrasound, 2 simple interventions. It was a community of high-risk OB patients, and his private practice of 3 physicians accomplished that. My grandfather, my mother is here, he was a general practitioner in Northeast Mississippi. He was the only Black physician for about a 100-mile radius. He went and visited his patients. He not only delivered care in their homes, but he recognized the nutritional challenges that his patients were having. His wife would cook food and take it to them. I had the fortune of knowing this man when I was a small child. My parents both believed the equalizers in life were access to health care and education. And that's fundamentally what we do in academic medicine. So when I say we're a product of our environment, we take our family values, we take them through every organization, every institution that we interface in, and it helps us create our values. My most personal value of importance is impact. When I look at the timeline over my career, I had the gift of going to Pembroke Hill. My parents made a sacrifice for me to go to school there. It's the same school that Dr. Norbash went to. We've been able to share some stories. What I learned there is freedom with responsibility. You can be free to speak, but you need to be responsible for upholding the values of what you're speaking of, which I have carried through my entire career when I talk about healthcare and access and really serving the patients that we all deserve good healthcare. UMKC School of Medicine, innovation and education. We uphold these principles of excellence and innovation to get through a program in 6 years. and community impact facing our communities. When I was a medical student, I did some time at the NIH. I wanted to be an otolaryngologist. It's a competitive specialty. We had no program here. We had no department, so I knew I needed to do something to improve my application. So I applied for a scholarship program at the NIH, and that's really where I learned how to observe patterns of observation and develop critical thinking skills and problem solving, which I still apply today. I spent 18 years at the Mayo Clinic, a premier institution, coordinated care where the needs of the patient come first. My time at Cincinnati Children's really drove the concepts around process improvement and quality and safety for high-value excellence. And I've spent the last decade in Chicago really looking at what can we do to help every child reach their full potential in a broad socioeconomic patient population. To gain the additional skills to really navigate conversations around health equity and cost, I received an M.B.A. in my 50s. So those of you, keep in mind, it's lifelong learning. I also say that our lived experiences really shape our values. I would say here are some of my lived experience that really helped me to become who I am. Firstly, I'm a third-generation African-American physician. My grandfather and my father, community-facing, and I understood the impact of that. They also worked in areas with limited resources, and they were innovative in their care delivery models. So that helped me develop this sense of impact and innovation. They also knew that I would have to demonstrate excellence to be on the same playing field throughout my entire career to be able to excel. They gave me the opportunity to be a competitive figure skater. That meant early morning, 4 o'clock on the ice. It drove excellence, but I think the most important thing is it drove an ability to learn from my coaches and continual assessment of how do you do better, how do you be better, how do you learn? That's what helped me become a world-class surgeon. I've had a journey of many firsts as an underrepresented minority and a woman in the surgical specialty of otolaryngology, and my presence has represented change in every environment I've ever been in. My thoughts, my vision, and my actions have not always been included, and so inclusion is an incredibly important value to me. And this has shaped an experience of leadership values around advocacy. I've also experienced physician burnout. How many in the room have experienced burnout? It's real. We're being asked to do more with less, which is resiliency. And really, I have a goal of how do you make the environment better and how do you support each other. So as I said, change has been part of my paradigm my entire life, and we're in this century of rapid change. The reality is the world is volatile, it's uncertain, it's complex, and it's ambiguous. The competency and the skills that you have today are going to be quickly irrelevant. Know that as you are in medical school, it's going to quickly change. I was saying yesterday, who would ever have thought generative AI would spit out a differential diagnosis that Dr. Spong and I spent hours memorizing? You know, it's just so rapidly changing. So that means that the ability for the workforce to learn a new skill and adapt is going to be essential for the next generation of leaders and for the workforce in healthcare. And I think we also have to recognize that the changing demographics in our country, and the census projects that by 2045, the majority will be multi-ethnic, and that is in the era where healthcare and equitability and access are not equitably distributed. So how do we think through this? One of the values of a market economy in the United States is it has driven disruptive innovation and transformation, and that's clearly happening in healthcare. This will make healthcare better. This is one of my faculty operating with a robot and a child's larynx. He can now do this operation in 1 hour, where previously it took us about 6 hours. It's impressive, isn't it? We now know the value of telemedicine. We're targeting genes. We're doing wearables. This is changing healthcare for the better. However, we are a $4.5 trillion enterprise, and the business of medicine is rapidly changing. The Affordable Care Act expanded access, and cost is escalating. So some of the solutions to cost have been mergers and acquisitions and alliances. We talk about government and private insurance and the reimbursement rates, and we all try and see How do we administratively optimize so that we can keep the doors open in our hospitals? Reimbursement is changing. We are probably going away from fee-for-service and evolving to a value-based payment model. Unfortunately, we now are in a fee-for-service model. We have an emphasis on productivity and work RVU with escalating costs and limited resources, which is burning the workforce out. The impact of that is not unsubstantial. It's also driving up the cost of care. Burnout costs $4.6 billion per year, and that averages at about $7,600 per physician per year, not an insignificant amount. Then when you have a physician that is burnt out, they leave their institution and go somewhere else, and I can attest to this as a division chief, it's between $200,000 and $500,000 as soon as a really talented physician leaves your organization. So this is a real consistent challenge for all of us in healthcare. So it's really starting to think, how do we create that environment with the resources that we have and the patients that we take care of? 2020 became that watershed mark for us to really understand the health disparities and the challenges in the US health system. A once-in-a-lifetime, I hope, pandemic, and then civil unrest really disrupted and helped us understand that equitable care is not part of the US healthcare delivery system. So our systemic inequalities are a public health crisis, and it really requires us to think creatively, have observation, and be committed to change. So as we think through change in addressing healthcare costs and what we do as physicians, the Institute of Medicine, starting in 2007, really instituted the triple aim. What can we do to improve patient experience, have better outcomes, and lower costs, which has really driven this culture of quality and safety and process improvement. And then as we've progressed, we've also learned that clinician well-being is an essential part of the sustainability in the future. And then 2020 really brought the understanding of the quintuplet aim, and that is a focus on health equity, because if we can do that, we'll have better health and an improved economy. I don't have all the answers, but I will provide some suggestions and thoughts, and some of them may be provocative. The first is, what is health equity? It's everyone should have a fair opportunity to obtain their full health potential, and that no one should be disadvantaged from achieving this potential. And to achieve health equity really requires diverse teams, because diverse teams are going to bring diverse perspectives and understand different patient populations. So to do this, it really requires valuing everyone equally with focus to ongoing societal efforts and avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. So that means that we learn from each other. One of the beauties of the UMKC program and the docent system is we are taught from day one to learn from each other. Diversity does matter, whether you hear the backlash or not, and it's essential in healthcare. Particularly with an evolving multicultural society, diverse groups are necessary to sustain our future, innovate better at complex problem solving, alternative viewpoints. We develop compassion and tolerance for each other. And then it's the alignment with where the challenge is diverse teams have been proven to have better outcomes and better financial performance if we borrow from understanding from our business partners and community. In June 2023, the Supreme Court affirmative action ruling impact on health equity and diverse teams is left to be determined. It's become polarizing and politicizing. And unfortunately, healthcare is the new battlefront for anti-DEI attacks. I always like to try and look at what are the possibilities. So we have the backlash, and so we also have to understand we're going to have to rebrand what is DEI. If we rebrand and really think about DEI as inclusion, if you include people, if you include everybody, then you're diverse. And then when you're diverse, that's when equality happens. So perhaps that's the order. I think we have this debate, is it DEI, is it EDI? And now the proponents are DEI or not, and then others are saying DIE. We have to really think through that and change that mindset. Our business colleagues have started to rebrand this as ESG, environmental, social, and governance. It's kind of a catch-all phrase for the range of ethically responsible business practices. I would encourage us to think about ESG to healthcare. ESG, environmental and social. So if we look at the pie of healthcare outcomes, it's 10% coming into the walls of the hospital, 10% focusing on genes and biology and our research efforts, but it's really the other part of this pie that really determine the healthcare outcomes. So if we apply those same concepts to where others are thinking and start aligning our payment models, then perhaps we might make a dent. Which brings me to governance. Current state governance in healthcare and how dollars are spent on sick care, not preventative care, not proactive care. It's spent on sick care. And we're incentivized to provide sick care. And sick care is really only 20% of the outcome. So the time we have spent in medical education is focusing on 20% of the outcome. I find that profoundly an opportunity to change. So when we think about healthcare expenditures in the several past years here, we look at the 1960s to where we are now, we can see how much growth has happened. Watershed events, 1965 is Medicare or Medicaid, which increased access. Increased access is always going to drive costs. More action in 2010 with the Affordable Care Act, and then the last decade we've had Medicaid expansion. So that is part of why costs are escalating, is we've increased access, so we're increasing cost. Which leads us to medicine's greatest dilemma. This is William Kissick. He's a medical economist. He was part of the team that helped pen in Medicaid and Medicare, and so has a very great perspective on this. And he reminds us that the golden rule of healthcare in our society is that everybody deserves the finest healthcare attainable, provided someone else pays. And then he coined this term, the iron triangle of medicine. So if you increase access, you're going to increase cost. And then when you get an imbalance in any one part of this triangle, it's off balance. And so how do you create the balance? It's looking at quality, but we have to redefine what quality is and really thinking, how do we generate quality by seeing the holistic view in which we take care of patients. Current state healthcare in the United States is a fee-for-service model. Our incentives are misaligned. We are paid for volume. We have evolving incentives around quality measures and evolving incentives around providing efficient care, few financial incentives to focus on preventative care, and the status quo does not promote health equity. And so we have this paradox in the United States of why are we spending more and getting less? And the reality in the United States is we spend almost 20% of our GDP, $10,000 per patient, and our outcomes are in the bottom quartile of all other wealthy countries. We have the worst performance despite our spending. For what we spend, we're certainly not living any longer, we're living less. And shockingly, we underperform in equity. The answer that has been proposed for the escalating costs in medicine is the concepts around value-based care. This is work, Potter, where in the numerator is quality and in the denominator is costs, and quality is defined as patient outcomes, patient experience, and cost reduction processes. And the goal is that this is going to transform healthcare. And as we think through from the lens of value-based care and taking care of our patients, we have to redefine what patient outcomes are. When you come to medical education, you develop your individual clinical expertise. We create available best clinical evidence and guidelines to practice. But it's really until we start understanding our patients, their values, and their expectations, that's when we're really going to define what the numerator of patient outcomes are. So if I were redesigning this formula and through the lens of health equity and inclusion, here's what I would do. In the numerator, we really have to recognize that we have access to care and that it is increasing, but we have to look at the social influencers and the patient influencers, also known as social determinants of health. We have to think about the environment, and we have to think about the behavior in which individuals bring to their health care. Then we have to really think about how do we optimize patient experience, and you can only optimize the patient experience if you're supporting the healthcare team in doing this. This is how I would modify this, and this has been the basis of all of my work. Even the Commonwealth Fund and many others say promoting health equity, we have to change how we pay for care. And paying for care, we have to address the social determinants of health, and we have to find a way to incentivize equity. Why do we need to do that? The economic burden of racial and ethnic disparities grew by 41% from 2013 to 2019. This accounts for 2% of the GDP. This is not insignificant. We look at the burden of this challenge. It's mostly in our Black and brown communities, and the drivers are excessive premature deaths, lost labor market productivity from lost time from work, and excessive medical care cost. And the burden of person by state, you can see that I live in one of the highest burden states. And so that's really driven us to think through what are the equitable opportunities and the inequities in the Chicagoland area. So as I point out this map, I just want to, as a pediatric otolaryngologist, I just want to kind of let you see where the density of pediatric population is in Chicago, is in the darker areas. You'll also note that that density correlates more with our Black and brown communities. And you're also going to note that that density correlates more where the Childhood Opportunity Index is red, meaning it's lessened. If you were to take the 1940s maps of redlining and overlap it with this, it appears the same. So then you know what the driver was, and you know where the opportunities are. So I'm going to give you a tale of two tonsils. So the first is a 12-year-old, referred to our organization with sleep disorder breathing. The PCP sent the child after seeing the child. He had a 1-year history of poor sleep, poor school performance, wetting the bed at age 12, pretty clear cut for obstructive sleep apnea. PCP noted 3+ tonsils. Child was okay for weight, and the PCP counseled the family, said, you know, your child would benefit from adenotonsillectomy surgery based on a clinical care guideline. That's why we have clinical care guidelines. Parents' fear of surgery, they insisted on a sleep study, which showed, surprisingly, not surprisingly, moderate OSA. Child came to our organization, had their surgery, overnight observation due to the sleep apnea, recovered, went home, went back to school 12 days later, symptoms resolved, uneventful. Here's the other tonsil, came in around the same time, 12-year-old, referred by the PCP, abnormal sleep study. This child's pathway was quite different. 7-year history of challenges and was overweight. Similar to the other child, poor school performance. His breathing pauses were noted by his older sister. Why? Because mom is working. The older sister is taking care of the child. Mom had to ask the primary care provider for a referral because the PCP didn't even look in the mouth, so the mom had to be the advocate for the child. Took 9 months to schedule the sleep study, so delay in access to care. Sleep study didn't change my management. It showed OSA. Child came in, had adenotonsillectomy surgery, postoperative respiratory distress, needed to stay in our intensive care unit, returned several days later for pain and dehydration, and had persistent OSA despite a surgical intervention because of environment, food desert, and is overweight. So what's the difference here? As I said, 9 months to schedule, PCP didn't look in the mouth, PCP probably in a community health center with 100 patients, so had to come up with the easiest way to get this child access to care. Delay in care. The test didn't change management. It only added $5,000 to the cost of care. Child had increased risk factors to the cost of care, and his symptoms were not resolved. So if we talk about the economic burden just from the fees, I'm not talking about the administrative fees to get to the hospital, but just from the fees. The child who had the great outcome, $11,000, north side of the city. The child with the challenged outcome, more money, south side of the city. This is a reality every day. And then you add educational levels. This mom had less than a high school degree. And then you look at the economic impact, which is equivalent to the 5% of the GDP. So health and education are drivers. We publish about this, but what do we do about this? Black versus white children are less likely to have a referral. African American children's rates of fever, dehydration, and needing narcotic medication are higher. We publish about this, but what are we doing? So what we're doing in Chicago, and this is where the proprietary technology is coming in, is how can we innovate? So the problem statement was the rate of rehydration or dehydration is high, and the rate of readmission after tonsillectomy is somewhere between 5 and 15% nationally, 7,000 per patient, so about $750 million per year. It's most likely due because they're not getting good pain medication, so they don't want to drink, and then when they don't want to drink, they dry out and they have a bleed. So it's improper utilization of pain medication. So we had a goal, what can we do to help parents with managing their pain, reduce preventable ED visits, optimize their outcomes, and develop a predictive tool. So we know that the penetration of a cell phone is about 98%. So everybody has access to a cell phone. So we have a MyChart app. It's an interactive process for our patients to use through their entire care episode. So again, you can see the diversity in our team that helped develop this. So when the patient sees us, they get signed up for this MyChart app. It walks them through the scheduling process. It walks them through visiting with their primary care provider. Then that information is sent to the hospital so we know how to plan for the operation. And then in the postoperative phase, they have questions that are triggered to allow them to monitor their child's pain and enter pain control and rates of fluid intake and when their child's going to the bathroom, and that's part of the predictive model that we hope to create from this. I think personally the coolest thing about this is I can monitor the data, and I've become a data geek. So in our Power BI dashboard, we know how many patients are enrolled in the tonsillectomy pathway. I know which of our providers, our APPs and our surgeons, are signing patients up for the pathway. So I know where to go when our surgeons are not advocating for this. And then I can also break it down by race and ethnicity. And then we can overlap it to the map of Chicago, and I can see the highest density areas where the app is being used. And you'll see that the dissemination of the app, the dark purple, is throughout the entire Chicagoland area, the north areas, the south areas, the economically challenged areas. And so if we can continue to impact and be able to drive the ability for parents to be educated and monitor and have a predictive model, we're going to change the outcome. So that just brings me to how you think through these opportunities of using innovation and digital health to monitor and to create opportunities for monitoring and decreasing complications. So then you've got to talk people into this, and that's where the narrative is. So if we were to take this model and scale it, 500,000 tonsillectomies a year, we reduce the risk of readmission. We're all judged on our quality metrics about readmission and 30-day visits, and our third-party payers ding us for that. So this is proactive in that domain also. The return on the investment to the hospital decreases the cost of readmission, and I would advocate that those dollars can be used for other patients. And then for us, it's actually intellectual property, that we hope to market, and it becomes, a return on that investment for our organization. But I would say probably most importantly is the other impact: patient quality of life, caregiver peace of mind. We can monitor the surgical outcomes. Hopefully we can reduce the burden of disease. This is a prototype for value-based medicine. Allows us to develop algorithms for predictable pain optimization in the future. And then it allows us also to develop scholarly work in data science and AI and predictive analytics. And we use this for scholarly work. So this is the field of implementation science, where you take your innovations and you effectively implement them, and you look for the enabling context to do so. Then it can lead to socially significant outcomes. So in encouraging all of the young students here that are going out is, what can you do to expand your mindset and bring creativity to your problem solving? So as we do this entire journey through better health and improved economy, you have to remember the tactical ingredients for the quintuplet aim: safe, effective, patient-centered, it's timely, it's efficient, and it's equitable. So here's another example of an opportunity we had in Chicago. So when I arrived there 11 years ago, what I learned is there was a differential access model for a child with recurrent acute otitis media. Even one of my colleagues had published on this, that the disparities in otitis media were impacted by insurance status. So we found that those with commercial insurance were seen more frequently, no surprise, and those that had government or were underinsured were seen less frequently. This is coupled around the same time, published in the New England Journal of Medicine. 2 investigators did a cold call to practices in the Chicagoland area in all of the specialties in pediatric medicine. So when they called an otolaryngology office, if you were commercially insured, you got an appointment 100% of the time. If you had government insurance, you got an appointment right away, only 37% of the time. So we asked ourselves, what can we do to problem solve this and reduce that time frame to access to care? So again, aligning with the strategic vision of the hospital at the time, I always like to align and find the resources. So what we do is we work with our primary care providers in the community. They identify high-risk patients. The office screens them. Now we've applied AI to this and other predictive tools, but the hospitals we screen, and then we know a higher probability of which child is going to need a set of ear tubes. We bring them in that day, NPO, they see an advanced practice provider, and then they go to the operating room. So by doing so, we reduce that timeline in some of our most underserved patient populations from 9 months to 1 month. So it's just thinking innovatively, and then this became a scholarly opportunity for one of my partners who now has become one of the world's experts in efficiency and care delivery, at least in otolaryngology. So if we were able to scale a model like this and add predictive analytics all the time, you know, we saw when we first rolled out this program a bump in our surgical volumes, and then when we added digital health tools, we saw even a greater bump in our ability to scale this. And the outcome of this, when we looked at this from a socioeconomic perspective, reduced time to access to treatment, high patient satisfaction, we found families were willing to travel for this unique service, so addressing rural health also. We found a savings to the family from less time lost from work, which was most impacted in the Medicaid population. So again, it's thinking through these holistically, and again, it was another scholarly contribution for a faculty member. So as we think through 21st century healthcare, and as I said, I would reframe this value-based equation, but I also want to frame how do we think about the patient experience and the healthcare team experience. So in Chicago, many of our practices have a high volume of patients that speak Spanish. Unfortunately, I didn't learn that in the 6-year B.A. M.D. program, and I wish I had. But nonetheless, one of our faculty was just like, I can't have any more Spanish-speaking patients in my clinic. I said, you can't say that. You know, he was just voicing his frustration. I said, so how are we going to solve this? So the problem statement, when you think about PI and QI as ways to think through innovation, the problem statement here was increased length of clinic visits for all of our Spanish-speaking patients, and the interpreting services were challenging and varied. It's either the phone or the telepad, or calling and waiting for a Spanish interpreter, and the families and the providers were frustrated. So we took principles of PI and QI and did a fishbone analysis, and then we decided to embed a Spanish interpreter in our ambulatory clinic setting. I pay for the Spanish interpreter through philanthropic dollars, not operational dollars. I just want to repeat that, philanthropic dollars. And so once we embedded the Spanish interpreter in our clinics with the highest volume of Spanish-speaking patients, we were able to reduce the cycle time per patient by 9 minutes, which allowed us to add an additional 1,500 visits into that one clinic, which translated into 400 additional surgical cases, which of course the hospital likes when you talk about volume and revenue. So again, it's that alignment. And then I had our statistical team do actuarial statistics, and if we were to scale this model and apply it to every clinic with high volume Spanish-speaking patients, we would generate 29% more capacity in the ambulatory schedule, translating to 31,000 additional visits without building out additional hospital space. You know, so it's thinking creatively around these solutions. But again, I feel the more important things for me is it reduced the no-show rate, families were more engaged, patient experience and satisfaction scores improved, the provider experience improved, the burnout in our team decreased. And so the next step that we're doing now is really studying the impact on patient care of being able to do this. And again, the person who addressed this as the pain point got to be the first author on the paper. Here's what our Spanish-speaking patients sent. The telephone should actually say the telephone is not very practical. It's practical, but we are Hispanic. We are very sensitive, very emotional. There's no feeling with that apparatus. We do not feel comfortable with the machine. We feel comfortable with the person. So we're treating the person. So when we plug that into the value-based medicine equation, the patient care experience is improved, the healthcare team experience is improved. This brings us back to how the United States thinks about spending healthcare dollars. So if we look at all the other Western developed countries and even some that are less developed, you're going to see that expenditures in healthcare, we spend more on healthcare expenditures than we do social service expenditures than any other developed nation and even some of our underdeveloped nations. So remembering that social, environmental, and behavioral determinants of health play a very large role. Perhaps we should start reframing how we include social service expenditures into our business plans and showing that return on the investment. So that gets us to 21st century healthcare and how do we balance from inequity to equity, disparity, and parity for the access to the dollars that we spend and balancing out this iron triangle of medicine where we've had increased access, increased costs, but we must redefine the numerator of quality. It really requires a mindset for adaptation and growth so that we're not insular or segregated in how we practice, how we care for our patients, how we advance the science, how do we educate the next generation of physicians, how we work in our teams, but we must see the potential in all. And that is really where health system science really comes into how we change the next generation. And I would argue that UMKC has been doing this since its inception. You know, when we think about traditional academic medical centers, we always think of what is basic science and what is clinical science. But what is health system science is really thinking about the patient, the family, and the community, and then developing those skills to problem solve some of the greater societal and social issues. I would say that the 3 areas that I've focused on in the last 20 years that I think have been really helpful to me is I learned Lean and Six Sigma and process improvement, and then later received a healthcare M.B.A. So as you think through problem solving and doing and believing and being, it's really that intelligence cycle and connecting the dots. You see the patterns and you have knowledge that is kind of just spread out, and then you start evaluating it and collating an analysis, so that continual loop of thinking and process improvement. And then you start connecting the dots and seeing your experience. So you take these hypotheses and you test them. It's just like a scientific study. So I ask the hypothesis of, what if we did this? What is the outcome? And how do you study it? So regardless if you end up being a clinician, a researcher, or a community health physician, applying this intelligence cycle analysis will really help to think about creatively connecting the dots and apply lifelong learning. And the answers will come through looking at the outliers as opportunities and adding creativity and knowledge to your experience. So the same dots, the connected experience, and look for some other way to be creative. The other thing to think through is, how do we forward health equity? I just wanted to kind of show some work from one of our medical students at Northwestern. And I just posed this question to him. I said, well, who's excelling in health equity in terms of specialty? And so he did a PubMed search, and he just basically plotted this by specialty, and you'll start to see the trends. 2019, 2020, social unrest, COVID, the number of publications excelled. And the areas that are the highest performing are going to be in family medicine, as you'll see, and also in internal medicine. So what are they doing differently in how they promote, how they recruit, how they retain, how they grow, how they balance their talent? I happen to be in one of the poorest performing specialties in terms of diversity, equity, and inclusion, and also one of the poorest performing specialties in publication and health equity. So when I asked myself about this pipeline, how did I get into medical school and walk through this pipeline to be the first African-American woman professor in otolaryngology, head and neck surgery in the country? I would say that there are key aspects here. Firstly, it was the values of my family. I would say another is that as I entered medical school, I was part of a pipeline program here. That pipeline program opened the door for me to come to UMKC. That's the Summer Scholars Program. And as I entered through medical school, I learned the value of mentors and sponsors and teamwork. And as I went through residency, it was really my mentors, my sponsors, and my allies that really helped support and believe in my ideas and create pathways and open doors for success. Which brings me to why mentorship, sponsorship, and allyship is so important. For me, I had to be open to who I would be mentored by. I call this my wall of 8 white men. And if I had waited to be mentored by someone who looked like me, I never would have been mentored. These men, including Dean Novak, are all special to me. Michael Heaney was a graduate of the School of Medicine in 1988. I literally got on the phone and cold called him. I tracked him down through the Mayo Clinic operator. I didn't really know him very well, but I found him. And I said, I go to UMKC and I think I want to do otolaryngology. And he was just open to being a really great mentor and opened that door. So again, just emphasizing these lifelong relationships and connections that you will have as a graduate of the School of Medicine. So through this pathway with my 8 white men, I told them stories. They learned of my vulnerabilities. They learned of my challenges, and they became my lifelong allies. So I would say one of the key attributes to diversity, equity, inclusion, and sustainability is to recognize the importance of mentoring inclusively. Leadership, I say, is an honor, and it's a responsibility. It's important to develop your leadership style. Mine is to inspire transformation, and my most important value to myself is impact. I demand excellence. I want to include possibilities, perspectives, and people. I want to challenge the status quo and innovate, but also know that this journey of being an innovator and challenging the status quo and swimming upstream does require resilience. As I mentor, I sponsor, I lead, I believe in consensus, coaching, engaging people in conversations. Most importantly, taking all of that and aligning it with the gaps and the opportunities of the environments in which you work. I believe in participatory governance and delivery and sponsorship through all. Leadership really is a privilege. So what can we do as institutions? We really have to move beyond bias training and education to intentional efforts of promotion and retention. But to do so, we have to provide psychological safety in our environments. We have to coach our leaders, not just in confronting bias, but we have to mentor in this area and become allies and learn how to become allies and teach how to become an ally. We have to provide coaching for people. I mean, I will tell you, I showed up not always my best. I would show up reactive very early in my career. And fortunately, I had people who would just pull me aside and really reframe that for me. Also, we have to commit to health equity goals in our long-term strategic planning, whether it's in medical education or in care delivery, and try and understand what is the revenue impact to the organization as framing that. And that's one of the things that I've really tried to do in the last decade of the work we've done in Chicago. And then evolving the quality metrics of the organization to also include equity. What can we do as leaders? Psychological safety for the environment, recognizing the challenges of underrepresented minorities in medical environment, and have an intolerance to bias acts. You know, we apply these principles of high reliability organization concepts and look at root cause analysis for all of our safety things. Perhaps we should be applying that when we see things that represent unequitable care or unequitable acts. Provide compassion and real-time feedback as derailers of perceptions, and train the next generation. I would say for those of you who are walking this journey like I have, support each other, share your lived experiences, and networking. Dr. Spong and I had a dinner 36 years ago. We went to a nice little Mexican restaurant on Southwest Avenue. I think we both recognized we were both going to be in academic medicine and had a really great conversation. So thank you for being here today. You brought literally tears to me earlier, so thank you for being here. I think the other thing is understanding self-awareness, how we might respond to the challenges in our work environment and how they influence how others are experiencing you. What do some of us experience? It's bias and microaggressions. Some of us experience that emotional tax of being on the receiving end of biases and microaggressions. And then those of us also are asked to solve these problems. That is called the minority tax. And sometimes we have to show up and be something that we're not, and that's called code switching. So just have an understanding that that is part of the journey and how it shapes you and how it will influence you. I would say recognizing mentors, sponsors, and coaches don't have to look like you, and creating an entire environment for allyship and asking for psychological safety in those conversations and sharing your lived experiences. So again, just to remind you, why do we have this imbalance? Because of the socioeconomic factors, which include race, ethnicity, and many others, actually influence the other half of the pie in healthcare delivery. We have to begin and continue to see our patients from the lens of their values and their experience to really change the numerator of value-based care. And I just thank you all for reflecting. Of all the inequities that exist in injustice in healthcare is the most shocking and humane, Martin Luther King. Thank you. I welcome any conversation, comments, reflections.
Dana, great job, and so fun to see you again and to see all you've accomplished and to hear your words. How do we get the culture of psychological safety in an era post-pandemic, post want to be part of the team, don't want to do anything more, want to be transactional, want to be happy to take a survey and just trash the person on the survey because no one knows who's saying it?
It's a challenge, I think, for all of us in leadership, and I don't know that I have the answer. I would say, firstly, for me, when I'm on the receiving end of that, I really have to focus on my values, because I know I'm gonna have to have really difficult conversations in this process. But I always bring it back to, why are we here? It's taking care of patients, and what are the barriers and obstacles that are in the way for you as an individual, and how can I help? I really try and come to that with curiosity and empathy. I would say the time it involved in that has changed how I am as a leader. And it's become a priority to say, okay, I'm gonna drop this right now and reinvest my time in that. And like I said, I don't have all the answers, but I find people they're just tired. And sometimes it is recognizing that they are tired and recognizing that you're gonna listen and say, how can you be part of the solution? Like the one surgeon of ours that talked about the Spanish-speaking patients, it was so unlike him. I mean, it was a gap in how he normally shows up. So when you see these gaps in how people normally show up, you know something is not right. So I just said, hey, wait a minute, let's problem solve this. And then I just gave him the platform and the tools to go and grow, and it gave him a different sense of purpose. And now that he had this different sense of purpose, then he has a different sense of engagement, so. Dr. Jackson, Dean Jackson.
Thank you so much for a wonderful presentation. My question is this: you have given us such food for thought and truth. So how important is it that we remain optimistic as we move forward to transform healthcare? And I say that with the knowledge that tomorrow we're going to be graduating our students here from UMKC. And I will tell you that I'm inspired by them on a daily basis. And that is part of my optimism for the future. Can you reflect on that?
This isn't going to be possible without being optimistic. It just isn't, and I think we have to realign to help people see the optimism and not the other side of it.
And be inspired by the vision that you shared with us. So thank you.
Yeah, and I think the other is we have to find some way to give physicians some autonomy back into how things are done. And right now, this vision of what I'm outlining for value-based care cannot be done by an administrator, cannot be done by an insurance executive, it can't be done by anybody in government. It can only be done by the healthcare team. And we need to re-own that and replenish that. And I truly believe it's going to be a partnership between academic and community medical centers that want to study this and bringing innovation and partnering with industry to be able to do this. I don't think it's going to come from the government. I think it's going to be incremental transformations, and whoever can do it and grow it and scale it, and then influencing the policy from that perspective.
Thank you for that.
Yeah, quick question. How are you planning on monetizing your app?
Well, part of it is we're working with Epic on part of that. I think that that's probably going to be the major pathway for it. That's one direction. The other is working with the third-party payers in terms of.
You're just going to sell it to Epic, or do you think the third-party payers will do a subscription model or something to save money?
We're exploring all of that right now.
You should talk to Dr. Spertus if you don't know him. He plays in that space in the cardiac area. He would be very useful, probably.
Thank you. I appreciate that suggestion. Dr. Boxer.
Thank you for the talk. I was just going to mention a couple of things, thinking about some words you used. One of them was mentoring. There's an excellent article on mentoring in the Pharaohs. So if you go to alpha.org and search and look at Pharaohs and search for mentoring, you'll find an article by Richard Binney, B-Y-N-N-Y, and it's really quite excellent about mentoring. It's not huge, but several pages long, and it goes through a lot of examples and things like that. The other thing I was thinking about, I used the word coaching once, I think, or so, is Atul Gawande. I imagine everybody knows who that is. He wrote a paper and a book, and in it he talked about engaging a coach to come and watch him operate and give him tips on how he could be better. He felt like he wasn't growing anymore, and it would really help him to take some feedback. So no matter how experienced someone is, I think they could benefit from an attitude like that, to be willing to let someone come and critique their work.
Oh, that that resonates so much with me, having been a figure skater and being coached by a couple nasty Russian coaches. But nonetheless, I think people who are in procedural services kind of understand that from some of their mentors. But coaching is universal in medicine. I mean, I've worked with a coach for executive presence. I have worked with a coach for how to mentor others. You know, I have also seen high performers that are on the way of derailing their career for one reason or another. And I have a fund. I said, let's work with getting you a coach, and here's the why behind it. And I think one of the other areas that I've used coaches for that I think is reflective of this presentation is I look at the PFE scores of members of our group and people who are on the lower performing of the PFE scores. You know, I try to understand the why, and then I offer them the opportunity to have someone come in and observe their time in the clinic and give them some real-time feedback. Thank you for mentioning coaching. It's essential.
Yeah, thank you.
Can I also acknowledge Dr. Greenspan? Dr. Greenspan was a year two docent for many of us. Insightful, practical, common sense, no nonsense, and really just asked us to think on our feet. So thank you.
Thank you very much.
This is really, I've been inspired being here the last day and listening to the students and your journeys and where you're going, and the questions that you ask really show that you're being thoughtful and intentional about your next steps and how you can be the best versions of yourself. So thank you for sharing with me.
Thank you.
Yeah, I'll figure it out. My brother's here. Yeah, I have your phone. Yeah, thank